Thank you very much for inviting me to share with you some results. This is a local study that we did in Brussels on trying to phenotype patients who became infected with SARS-CoV-2 and also to better precise the phenotype of diabetic patients who got severe forms. So this is a single center academic study, but we found some interesting results that I would like to share with you. So here are my disclosures. So as you all know, since the beginning of the pandemic, diabetes has been considered as a risk factor for severe COVID-19. But there is, on the other hand, no evidence that the fact of being a diabetic increases the risk of contracting COVID-19. Now, what is very confusing is that when you look at it, the two major risk factors for type 2 diabetes are the same as the two major factors for severe COVID, which is namely age and obesity. And the other problem is that factors predisposing to becoming infected or having severe COVID are usually subject to generalization that do not take into account the type of diabetes. And this is why we embarked on a study of both type 1 and type 2 diabetics to see what was common or specific to the different types of diabetics. And also, as you may know, because age and obesity are themselves contributing to affect glycemic control, especially the more obese you are, the lesser glycemic control you have. This is very confused and intricate. So what we did was to document the phenotype just prior to infections of a very well phenotyped cohort of mixed type 2 and type 1 diabetics that we saw over slightly more than 2 years, and then to analyze subgroups of specifically type 2 and type 1 patients. That's for the part becoming infected, and that we did the same for having severe COVID, analyzing in the global cohort of a mixed type 2 and type 1, and then in subgroups. Now, already here, we were not able to analyze a subgroup of type 1 diabetics with severe COVID because there were too little. We only got 5 patients with severe COVID with type 1 diabetes, so we couldn't even do that analysis, which itself is interesting. Altogether, we included 934 consecutive patients, about 2/3 of type 2 diabetics and 1/3 of type 1 diabetics. So here are the characteristics. If we take the overall cohort, I don't know if you see my arrow, but I hope you do. Overall, we got 20% of the overall cohort who became infected. And among those who became infected, another 20% got a severe COVID-19. Now, we define severe COVID as being admitted to hospital and or a death from COVID. The study lasted more than 2 years, so over time, increasingly more patients became vaccinated. We had, as I told you, 2/3 of type 2 diabetics, 1/3 of type 1. The majority was white Caucasian, but we had substantial ethnic minorities from Africa, especially North and Black Africa. Those who became infected were usually younger. This is usually found in all studies. We had no difference in gender. We had no difference in type of diabetes, but we had a much less prevalence of white Caucasians who became infected, since ethnic minorities are known to be more at risk of becoming infected for various reasons, most of them being behavioral probably. Now, the other characteristics of those who became infected, they had a higher BMI, which has not been well explained. Usually the more BMI you have, the more risk of becoming infected you have. Because they were younger, the GFR was better, and they were less often taking statin, which may be related to their younger age, and a slightly less prevalence of macroangiopathy. But I will come back later on those statins because this is the topic of the talk. So that difference in statins was seen even if we corrected for secondary or primary prevention, so they were just less often on statin. Now, when we look of those who became infected by subgroup, first the type 2 diabetics, what we found that, again, they were slightly younger by an average of 3 years. And here we have a more precise difference in statin use. So the overall statin use was 10% lower, but what was striking was the discrepancy among statins, with a much higher use of atorvastatin and a much lesser use of rosuvastatin. I haven't shown all the details, but the proportion of high-intensity statin was about the same as was what we call the statin equivalent dose, which is a normalization of any type of statin to atorvastatin equivalent. There was no difference in micro or macrovascular disease in those patients who became infected. What about the type 1 diabetics who became infected? Again, they were younger, this time by an average of 7 years, and hence their prevalence of macroangiopathy was much lower. Otherwise, there was a non-significant different use of atorvastatin, which was higher as in type 2 diabetics in those who became infected. Now, if we look at those who develop severe versus non-severe in the overall cohort, 2/3 diabetic, 1/3 non-diabetics, we just found everything that was reported. So being older by an average of 14 years, having type 2 diabetes, which of course is related to being older, having a higher HbA1c and a higher BMI, also a body composition with more central fat, as measured by waist circumference or percentage of visceral fat, being hypertensive and blah, blah, lower GFR. Everything was significant except for the gender difference. There was no gender difference having severe versus non-severe in these patients, which is usually less the case in non-diabetics, in whom male gender is more affected with the severe forms. And as regard macrovascular disease, there was no difference in macroangiopathy. Otherwise, look at heart failure, it just exploded, as well as atrial fibrillation. Well, all those conditions also tend to increase with age. If we look now at the type 2 who had severe versus non-severe forms, of course, the numbers are lower, so some of the significances will disappear. But what we found was, again, a difference in age, but only of 6 years on average. A less glycemic control, less good glycemic control, which I consider is probably just related to those patients being more obese and fatter. It was still significant for visceral fat. Those patients had more abdominal fat. They were more hypertensive and their GFR was lower, which is likely a result of age. Again, heart failure was evident as a condition raising risk of severe forms, as was well known from non-diabetics. What about the levels of lipids? Well, there was no difference, no significant difference in LDL cholesterol in both the combined cohort or the only type 2 cohort, since, as I said previously, we had too few type 1 diabetics with severe forms in order to conduct a meaningful analysis. They were mostly characterized by having more atherogenic dyslipidemia. Of course, those patients with severe forms were more obese, so it was not a surprise. They had smaller LDL, a lower level of HDL cholesterol, which has been suspected to be also involved in virus transmission and infectivity. HDL may be protective against COVID infection. And they had much more triglycerides and atherogenic dyslipidemia. So that was not really a surprise based on their phenotype. What we found, which was very odd indeed, was their use of specific statins. As I told before, there was no difference in statin equivalent dose normalized to atorvastatin. They were taking 21 milligrams in the non-severe and severe form, so exactly the same amount of statin, and a non-significant difference in high-intensity statin. It was not significant, but severe form patients were even having more high-intensity statins. But what was striking us for becoming infected was the much higher use of atorvastatin in patients who developed severe forms. This is the mixed cohort type 2 plus type 1, and a much lower use of rosuvastatin prior to getting SARS-CoV-2 in those patients who had the severe forms. What about Ezetimibe, again, there was a mismatch. Ezetimibe with or without statins was much lower used in patients who developed severe forms, as was the combination of any statin plus ezetimibe. On the other hand, the ezetimibe as a monotherapy was associated with severe forms, but the numbers were extremely low. Finally, fenofibrate, which is used to treat atherogenic dyslipidemia, was unsurprisingly much more used in patients who developed severe forms, likely a result of their AD. If we take specifically the type 2 diabetics with non-severe versus severe forms, again, we found that very odd and unexpected mismatch of high-intensity statins with the severe forms. This is only type 2 diabetics now, being more than twice often more used in those with severe forms, and rosuvastatin being almost exclusively used by those patients who developed non-severe forms, with again the same standardized equivalent dose of statins, but even a higher use of high-density statins, which is of course atorvastatin in this case, for those patients who developed severe forms. And again, ezetimibe use was much lower in those patients who developed severe forms. So if I summarize, for becoming infected, we found that a combined type 2 plus type 1 diabetic patients cohort is less often on statin just prior to infection. Specifically by subgroups, infected type 2 diabetics are more often on atorvastatin when they become infected and less often on rosuvastatin. The difference, if you combine both difference, is huge. In type 1 diabetics, there was no difference in statin use because, at the time of being infected, but still there was a non-significant higher use of atorvastatin in those patients who became infected. If we move to the severe versus non-severe COVID-19, what we saw was, despite a similar percentage of severe COVID patients being on statins compared to non-severe patients, and with the same statin equivalent dose, and a non-significant different percentage of high-density statins, the patients who developed severe COVID were more than twofold more often on atorvastatin. And for those who had non-severe forms, they were more than 4 times more often taking rosuvastatin. In relative terms, it was 434%. Ezetimibe with or without statins was also much lower in use in patients who developed severe COVID, was the combination of any statin plus ezetimibe. Now, I haven't put a hypothesis because the high-intensity statin proportion and standardized equivalent dose is similar. It's unlikely to be simply due to difference in statin use. Also, the difference remained when we did some other analysis, a univariate analysis, but if we look at primary versus secondary prevention patient and all those stuff, all the difference remains significant, and we at current level do not have any explanation for that. Thank you very much for your attention.